After going through the many of the journals as well as the many of the topics of these things, I found that there is nowhere it is different from the adult gastroenterology practice of upper GI bleed compared to the pediatric GI bleed. So here, most of the times the large volume of the blood, which is being bled by the pediatric population, which is resulting into fatality. Here the incidence, if you see, around 6 to 25% of the incidence we see in the patients with pediatric population of different etiologies in the world. If you see the upper GI bleed of the different causes, the neonatal causes, if you see, the swallowed mother blood and gastritis, a lot of lengthy of list is there, which I am not going to go through the list of that. And the age group, between 1 month to 1 year the age group, 1 year to 5 years age group, and 5 years to 18 years age group. Here the duplication cyst is the commonest of the etiologies in the 1 month to 1 year duration, and 1 year to 5 years hemophilia, 5 years to 18 is then H. pylori induced peptic ulcers. The commonest cause of pediatric upper GI bleed in Western conditions, if you see condition, Western nations, the mucosal lesions are common in Western conditions, whereas in India, varicose bleed is the commonest, and 40 to 95% of the children, they have been coming here with upper GI with varicose bleed. And rest of the varices, peptic ulcers and foreign body, caustic, they're all the routine conditions which we come across, these are all the common conditions we see of different age groups of the children. I think etiology-wise, if you see in Indian data and compared to Western data, the Indian data, the Mittals and Yacha's, whatever the publications at Dubey, this is the Dubey SRK who has been published in 2017, where the Indian population having the highest is the esophageal varices, next one is the esophagitis and the malarious tear. And compared to international data, the highest is being gastric erosions, next one is the esophagitis and malarious syndrome. That is been common. Rest of things all are relatively lesser in incidence. And if you see the portal hypertension in Indian population of the children, where the total case of portal hypertension and portal hypertension with bleed, portal hypertension without bleed, both the EHPO is the highest incidence of the EHPO is the common in Indian scenario. Next one is the cirrhosis. These are the two important conditions where the commonest reasons for portal hypertension in India. This is the Sheffield scoring system. This is internationally accepted scoring system. When and where the interventional gastroenterologist, the pediatric gastroenterologist, what situation he has to intervene. Here the total score is 24. The score more than 8, that's a significant score where supposed to the interventional gastroenterologist has to intervene. There the scoring, if you take, highest scoring coming to the need for blood transfusion. That is the score 6. Next one is need for fluid bolus, that is score 3. Papillary, then prolonged capillary refilling. So prolonged capillary refilling comes to score 4. So altogether, the HP trough is less than 2 grams is also very significant scoring. Here, a score more than 8, that is more significant part where the intervention is very much needed as early as possible they have to act upon. Here, let us see the roadmap towards the acute GI bleed. The immediate action, when the patient comes to our casualty, we have to see that venous axis. The venous axis to be central lines has to be kept it. If possible, two lines has to be required. Then the nasogastric intubation. Then the grouping, cross-matching and laboratory investigations are very much needed, whether the patient is in coagulopathy or not. And electrolytes, what are the electrolytes conditions that has to be taken care of. Then the resuscitation. Resuscitation part, the oxygenation is important. Intubation is very, very important because of aspiration is very, very commonest cause of death due to aspirations. That is the reason the intubation is very, very important. The hemocrit values are required. Secondarily, hemocrit values are very much required. At least for 4 to 6 hours after the total intervention of the children. Upper GI bleed, as far as possible, if the known varicose cases, varicose disease children, less than 12 hours we have to see the endoscopy has to be done. Whereas other than varices, suppose a mucosal disease, up to less than 24 hours we have to be done. We have to do the endoscopy and the location where exactly it is bleeding, whether it's from esophagus or from the stomach. So locate the bleed site so that we can intervene as early as possible. If it is a mucosal disease, you can go for clip or APC or the spray, hemospray. Suppose it is a varicose or gastric varices or esophageal varices, you have to go for either EVL banding or EST or glue injections. This is what we discussed before endoscopy, the timing of endoscopy. Less than 12 hours is very much needed. A patient, a children, known varicose patient, they require to be done endoscopy less than 12 hours. Whereas in a non-varicose cases, non-varicose cause of the GI bleed, we can do it less than 24 hours, so the yield will be more than 80%. If it is a 48 hours, after 48 hours, the yield will be very much less. For detecting rate will come down to less than 40%. Whereas the transfusions, the platelet transfusions are required whenever it is less than 50,000 platelet count. The platelet transfusion is very much required, as well as the actively bleeding lesions also required platelet transfusion. FFP, if you see, and less than 1 gram of fibrinogen levels, you have to transfuse FFP. And platelet count also, if it is more than 1.5 times, the transfusion of FFP is very much required. Of course, the octreotide, in a suspected case of varicose bleeding, octreotide is important in children. And the PPAs can be started in non-varicose mucosal cause of the mucosal cause of GI bleed. The PPA can be taken up as early as possible. Here it is a checklist which is being given, the big checklist before you intervene patients with those with the emergency upper GI bleeding children. Whenever they come to the casualty, we have to take care of all these things checklist. So before we go for intervention, the checklist is important. Then all the children require general anesthesia. So general anesthesia is very, very important for a sufficient period so that you can intervene very well. Then age and weight wise, if you can see, the less than 1 year, the scope size should be less than 6 millimeter size outer diameter, and the 2 millimeters should be channel. The port channel for the therapeutic purposes, whatever you use, the port channel should be minimum 2 millimeter size of channel is required for adequate handling with all accessories. And more than 1 year, as similar to the adult children, we can do it. Then the GI bleed, if you see, that grossly divided into varicose bleed and non-varicose bleed. In the varicose bleed, EVL, EST and glue injections are the varicose side. And whereas in a non-varicose bleeding, mechanical, thermocoagulation, electrocoagulation, that all those things are well known by most of the people of the gastroenterology. So the newer modalities like OTSC and hemospray also, that is being applicated in patients with adult gastroenterology also. Here varicose bleed, the banding ligation is a standard of care. If banding ligation is difficult in a situation, go for sclerotherapy. And band ligation and sclerotherapy both will be complementary. Whenever there is a band ligation, bleeding doesn't stop, go for sclerotherapy. Then subsequently, the EVL series and sclerotherapy series, if you see, 100% of the series bleeding control happened with EVL than the sclerotherapy. Dual phase lesions, of course, the hemoclip as well as the injection therapy that has been there, but the standard of care by hemoclipping as well as the banding, both are having the synergistic effect and the complementary each other. The peptic ulcer disease, what you know very well, that mechanical modalities are there, thermal modalities is there. So wherever is required, we start with injection therapy. Subsequently, we can go for hemoclipping and the thermocoagulation. Newer modalities like OTSC, that has been a better advanced modalities where the anastomotic ulcers, gastric perforation and bleeding peptic ulcers are being taken up as a very much latest and emerging modalities. Newer, the hemospray has been a very much interesting one, but not routinely been coming to our routine natural everyday day-to-day life. The hemospray is not been regularly used it. Whereas the emerging modalities like injection, thermal therapies and mechanical, all these been US guided angiotherapy and US guided this gastric varices also by coil the coiling also been done for gastric varices. So mechanical also very, very important. Then European guidelines have been taken here. Collaboration with pediatrician is required and required capsule endoscopy for small bowel disease. Whereas the lower GI bleed, if you see that various causes among which the polyps as well as the IBD, that has been commonest conditions for international trials, whatever the studies have been projected, all of them is called the colitis as well as the polyps is the commonest one. Before colonoscopy, the important thing is that the dose, dose which you are going to plan, the ml, that is for per kg body of the child, and this is the ml per 10 minutes of the period orally. We have to give till the clear fluid is going to come. So that has to be given by the what is the weight of the child that is taken into consideration. Here the interventional endoscopy is for lower GI bleed, like banding, fluorescent for hemorrhoids, AV malformations for the all the kinds of the hemoclips, and epinephrine can be given, and polyps. Polypectomy is done. Make sure that the colonoscopy should be done. Total colonoscopy is very much important before you go for it. Thank you very much.